Look, I'll just start. I mean, this is the second of the webinars for Hunter New England area. Just running through the 5 A's, which is ask, assist, advise, arrange, ask, assess, advise, assist and arrange. Got to get the 5 there. And just, we're trying to start the thing there. Yay, okay. So here we go. So the last one that we did was ask and assess. And so now we're looking at advise and agree. So looking at brief interventions, a little bit on motivational interviewing and negotiating goals. And then in the next one, it'll be assist, and then arrange will be the final one. So Amanda, have you got control of the slides?
Yes.
Oh, you're here. Go for it. Start. Go. We can hear you.
Can you hear me? Oh, thanks. I was just going to relax. And
Well, somebody's got to change the slides because I can't change them.
Did we just press?
yeah.
Yes.
So
Okay.
Right.
Beautiful. All right, I'll keep going. Just interrupt whenever you want to. And so here we are, Professor Amanda Baker, who's down there with Stephen and myself. And we've also got other people online, including Adrian Dunlop, who is the Director of Drug and Alcohol Services, and Craig Sadler, who's one of the staff specialists up there in Newcastle. Are there other presenters that I'm not aware of?
That's it.
That's it. Beautiful. Next slide. So we're concentrating on drug and alcohol and comorbid mental health issues. That for us in general practice, that's what we see a lot of. We see a lot of people that have got both. Now, all the ins and outs of how to do that. No, we're moving on from there. I don't know what to do about setting up the whole webinar thing. Maybe we'll just move on and hope that people can hear.
Yeah.
Does that sound like an idea? Fantastic.
Yeah, okay.
Okay, so bottom line, brief interventions. Yes, so brief interventions are effective. We know they're effective, and we do them all the time in general practice. We do them around helping people to change how they eat, to lose weight, to adhere to medications. We do it all the time, and they work really well. And they work really well in the drug and alcohol setting. You've got to pick your people who are able to really benefit from brief interventions, and there are others that have more significant issues that need further input. But what we know is that brief interventions really work. There's lots of studies that have looked at them, both in the primary care setting, in the ED setting, in terms of the opportunistic, short, sharp kind of interactions that healthcare workers can have with patients around drug and alcohol issues, as well as other lifestyle issues, and they work. So they're really worthwhile doing, and you can do them really quickly as well. So they're really effective in terms of time and general practice as well. Can we move on to the next slide? So the other thing we're looking at is motivational interviewing, and this is what we always say. This is a patient-centered approach to working with a person to strengthen their motivation, resolve ambivalence, and build a plan for change. And I'm hoping that Amanda, you'll run through that in a little bit more detail as we go through the webinar. You know, everybody put in your thoughts around that. One thing I would say about motivational interviewing is that it is a skill. It is an approach, and it's something that you need to practice and you learn, and you're always learning and learn over time. I would really encourage you, if you're thinking, Jesus, this looks really useful, is to actually do a specific, some specific training on motivational interviewing and actually learn the skills in more detail. So we'll move on. Ambivalence. Does anybody want to have a word about ambivalence?
I was just, I've already said twice, but no one heard me. But, you know, that's what you want to work. So, and then stays the same forever. So expect your patients to come in feeling 2 ways about change, and you know, you can't go wrong. You expect them to be ambivalent, talk to them on that basis and go with it.
Yeah. I mean, I think ambivalence is a normal part of life. You know, I like Tim Tams, but I kind of have ambivalence. I probably shouldn't eat the whole packet, but geez, they taste good. You know, it's part of being human.
Yeah,
and it's important.
I have a packet of Tim Tams when I get home tonight.
After the start to this webinar, we're all going to need a packet of Tim Tams, if not more. Okay, moving on.
Yeah, I'll just say from a psychology perspective, you know, listening is really key, and from any perspective, it's really important just to take that time to listen to what the person is saying, and not only verbally, but, you know, listening into observing what the person person is doing really well.
Yeah, yeah, absolutely.
Yeah.
And it is really that thing of having a conversation that is around supporting that person's experience and really hearing what they're saying. Perhaps this invites sustained talk. Does somebody want to speak to this? This is a cat trap or a possum trap.
Collaborating with the patient, not trying to direct them one way or another necessarily.
Yeah. So motivational interviewing is directive in a sense, but it's through the back door rather than the front door. And here we are with the front door approach that really invites sustained talk. And sustained talk is just a way of sort of saying, if someone's arguing for staying the same, then you know that you're not doing your motivational interviewing. So what you want to hear your patients sort of saying, what can I do to reduce my drinking, or what can I do about this, what can I do about that?
Yeah.
So you want advice. So that's what sustained talk is. And if you hear it, that means that you need to be, sort of change what you're doing to elicit change talk. And next slide. So this is something that we all fall into, and it's particularly something that when you get really super busy, you might find yourself falling into. This is one of the big traps, that you're giving advice too soon. So here the doctor's saying the best thing you can do is give up smoking, drinking, fried food and handicap best, and what's the second best? And that's inviting sustained talk. He's wanting to say, I'm not changing, mate, So he's arguing for staying the same, which isn't what you want to be doing.
Yeah, and it certainly is one of those things that it's so easy from the outside to see what needs to be done differently, and it's hard. You have to sit on your hands and stop yourself from jumping in with that advice too early. And you've done it as soon as they start going, no, that's not, yes, but, you've stepped in too early, and you haven't really gotten to what's going to work for them.
Yeah. Okay, so this is Stephen. You're going to talk about the nurses.
Yeah, so as from my perspective, there's really no reason that nurses can't be a part of all of this, and particularly given that we are the largest proportion of the healthcare service system, we really need to be doing this in collaboration with our medical and psychology colleagues, whoever else is involved. And it's certainly recognised by the New South Wales Ministry of Health. So in a set of clinical guidelines developed many years ago, the guidelines said quite clearly that it's within the role and scope of practice of all nurses and midwives to minimise the harm associated with hazardous substance use resulting from intoxication, withdrawal and dependence. All registered and nurses, midwives and assistants in nursing in New South Wales are responsible for adhering to the principles herein and for clinical expertise according to these guidelines. And these guidelines are available on the Ministry of Health website. They're freely available for anyone to read.
So they'd be one of the biggest workforce.
Absolutely.
Yeah, nurses, yeah. So if we can mobilise them.
If we can mobilise the nursing workforce, we win the war.
The war on drugs.
And so, as I was saying, the largest component of the healthcare workforce are nurses. And as a result of that, there's a very high contact exposure. So we're going to be seeing patients more so than our other colleagues. There is some good empirical evidence for these practices, with nurses rating as well as GPs in motivational strategies.
Surely not.
And brief interventions. We'll go back to the literature on that later. Nurses are already involved in recording information anyway, so there's absolutely no reason why they shouldn't be recording on diet, exercise, drug and alcohol use. But nurses also have a very real role in health promotion and in health education, both of which we're really covering by performing these practices.
Do you think people sometimes open up more to practice nurses than the GP maybe?
They sometimes can do. So I've been in situations where patients turn up wanting a drug, wanting a prescription. With a nurse being able to say, well, I can't provide that, how about I talk about this instead? It can open up a conversation that the patient wasn't necessarily prepared for when they first turned up.
I think there's also that thing that sometimes our patients are concerned, oh, geez, you know, doctor's busy, I don't want to take up their time. And nurses can have those conversations because they're seen as having a bit more time, being perhaps a little bit more approachable. And also certainly in my practice, my nurse in my practice does all the vaccinations and wound dressings. And, you know, she says she's in the treatment room, so she's kind of doing stuff. And it's a time when you can have that, a conversation which doesn't feel as pressured or as intense around doing something else, which can be a really useful way to engage with people.
Exactly, and it makes very good use of that time as well. So there's no reason that it can't be done while you're performing another activity.
Absolutely.
And certainly in terms of the SNAP guidelines, practitioners are acknowledged in those guidelines. And I won't go into each of these individually, but they cover the brief intervention and motivational focus very well.
Absolutely.
And that's just more in terms of the very specific elements of nurses being involved in the advise and agree component of the SNAP guidelines. So in terms of smoking, nurses can provide brief advice and motivational interviewing. Patients to set a quit date, for example. For patients who are overweight, it's very easy to advise on the benefits of weight loss and encouraging people to set goals. The same with poor diet, hazardous drinking, the same sort of motivational interviewing skills are useful. And again, the same for physical activity. So there's no reason why nurses can't be a part of this.
And I just wanted to add here that those behaviours tend to cluster together. So sometimes people will be willing to change more than one at a time. And in the old days, I think we used to think, oh, just do one at a time because changing multiple behaviours might be too hard. But it's actually been starting to show there's accruing evidence to show that you can change multiple behaviours at once and experience more benefit. And changing, for instance, your drinking helps you reduce your smoking. It's good to combine them. You can motivate the person to do so.
If you eat poorly when you're out drinking, it makes sense to stop them both at the same time.
Yeah.
I think the other thing, just thinking about some of our patients that have multiple drug and alcohol issues and mental health issues, is that we sometimes think that actually those patients don't want to change. But what is clear to me is that they do, and quite often it's hard. And so if you think about yourself, if you're in a situation where you want something to be different and it's really hard to make it different, it's an uncomfortable, emotionally uncomfortable place to be. So people will kind of go, oh, it doesn't really matter, when in actual fact it does. And we do need to put extra supports in because people in that situation have a lot to gain from actually changing their behaviours around that in terms of their physical health and their mental health as well. So just moving on, and we wanted to just try and get a sense of, the kind of patient that we see in our general practice. So first of all, looking at Mrs. G, who's attended your practice for many years, she comes in with her kids. You see her every time with her kids, but she comes in today and you notice she appears to be overweight. Yeah. So this is a chance that we have to start to intervene in what is actually we know is a really important lifestyle issue. And part of the 5 A's, the first one is asking. And part of this is setting the scene, normalising and asking for permission. So asking something like, as part of my routine review of all my patients, I always ask about lifestyle factors, including things like exercise, diet, stress, alcohol and other drugs. Is it okay if I ask you about these? Now, it's incredibly uncommon for people to say, no, it's not okay. It may be that they say, look, not today, doc, look, I've got to get up and pick up the kids in 5 minutes. I've been waiting out in your waiting room for an hour. It is possible that can happen. But people do expect us to ask about their well-being and their health and their lifestyle. And so the response that Mrs. G gives is, I'm getting a bit worried from time to time. I recently felt more overwhelmed. I'm not sleeping very well. I smoke cigarettes and drink alcohol sometimes, and it makes me feel more relaxed. I've never taken any other drugs. So what we're getting here is that she does get worried. She does feel overwhelmed. She has issues with her sleep, and she's smoking and she's drinking to help her relax. So in terms of going on from, we've set the scene, we've normalised, we've asked permission, she's opened up. And then so we're thinking, well, okay, smoking first. Let's do the assessment. Probably the most important question here is number 2. But I always ask number 1 as well. How many cigarettes do you smoke per day? But the second one is how much time after waking do you have your first cigarette? So is it on waking? Is the rollie already there by the side of the bed and ready to light up as soon as you wake? Is it after you have your cup of coffee? Is it at lunchtime? Is it in the evening? And this is a really good surrogate marker for the level of dependence you have on nicotine. So it's a really useful tool.
If you're sleeping poorly, Hester, it's quite possible smoking during the night as well.
Absolutely. Absolutely. So she's smoking 25 cigarettes a day. She has her first 10 minutes after waking. So that gives us a really good indication of quite a high level of nicotine dependence. But she stopped at times. She stopped when she was pregnant and she started again after the birth. So she has, in certain circumstances, she is able to change this behaviour. Her 11-year-old daughter is hassling her about stopping smoking. She's drinking 3 to 4 times a week and drinks a bottle of sweet wine. As we've heard before, it helps her to relax. She doesn't sleep so well without a drink, and her husband's worried about her drinking. So she's getting a bit of other people are worried about her behaviour, including an 11-year-old daughter. And if anybody out there's got an 11-year-old daughter, you know that they can really give you a hard time about things that you should be changing. And her husband is concerned. So there are issues with both these areas in her life. So you've gotten a good history there. You've got really good idea of what's happening there. What do you do next?
So if you read one paper this month, read this one. It's one by Robert Satz, and it's a nice clinical overview of brief counselling and referral. And this is just one example of what he's got for Advise and Agree. So he's got the whole article sort of in a tabular form like this, which is really very clinically helpful. So he says it's really helpful to provide specific advice in comparison with population norms. So in this case, with Mrs. G, you can say, 90% of women drink less than the amounts you report drinking, and then link the problems through alcohol use when appropriate. And so because of comorbidity tonight, that's what we want to do. We want to link alcohol use, safety and other things to, in this case, to make information relevant to the patient. So Mrs. G, you mentioned your husband's concerned about you drinking. What have you noticed? And he doesn't mention the stress. You might sort of bring up the stress with her and say, how is the drinking connected with this stress? And how does your smoking fit in? So what else would you say to Mrs. G, Hester and Steve?
So it depends on what she says, so what have you noticed? And so she's saying, well, yes, my husband is concerned, he gives me a hard time. And I might be kind of looking at, well, how is it, what is it what would you like to be different? What is it that you're worried about? What is it you would like to be different?
Yeah, and I'd probably ask Hester, when your husband says that he's concerned about you drinking, how do you feel about that?
Yep.
Yeah. Yep. All right, next one.
So Mrs. G says, I think I need to stop smoking. My friends have told me they're concerned about my drinking. I know I should drink less, but it really helps me. Amanda, how do you respond to that?
So, according to Robert Satz, he says when the patient expresses interest or gives permission, so that's really nice if you can say to your patients, can I give you some information about drinking, or can I tell you something about smoking, or would you be interested? That's a really nice in. So you don't, the handicap getting sort of a bit uppity about advice too soon. If you seek permission, that's really nice. So seek permission, provide information, and if you can, include a menu of options about how to change. So in this instance, would you like some information on how to cut down or stop drinking? And she'll say yes. Other people have found a range of options helpful, so kind of say that there's a range of things that people can do so that you're not specifically suggesting one thing. Give example like keep me a drinking diary, counselling, and even going along to some groups. What do you think about these? So listening, getting her opinion.
And certainly, I mean, I think it's one of those things, you're worried, geez, am I giving too much advice too early? But it's also the way you do it. Yeah. And, I've found generally with my patients that some of these can help. List your options. Do you think some of them might help you? And so it's a suggestion. It's not a you should do this, you know, you're a bit naughty, but it's this is what has helped other people. So it's normalized. This happens to other people. This is what's helped. Which ones might help you?
Definitely.
And also exploring the idea that I should drink less, but it really helps me. So in what way do you feel that your drinking helps? That then allows you to understand what areas you need to address in terms of offering education to the public.
Yeah. And look, and what she says is, I think I need to stop smoking. So she's she's further down the road towards starting to think about making change for her smoking, and is kind of going with that alcohol, not so sure. So you might actually then just, okay, well, let's have a look at how the smoking could be different. But part of finding out how that plays into her life is also, does she smoke when she drinks? Does she smoke more when she drinks? So how are they interconnected to each other? And are they both things that she uses to help manage her worries and her stress levels?
So one of the things, we're not talking about it so much at this point, but next week or next time we have the webinar, often a way in to help people think about reducing their smoking and drinking is to talk initially about stress management. There's many people interested in stress management, and then as a way of doing that, smoking, drinking and the other sorts of things sort of fall into place without it being a confrontation about smoking and alcohol.
Yep. So moving on, so as we've said before, Mrs. G said, look, I think I need to stop smoking. My friends have told me they're concerned about my drinking. I know I should drink less, but it really helps me. So in terms of her smoking, where do you reckon she might be in the stages of change? Is she pre-contemplative? You know, and so pre-contemplative people would be saying stuff like, nah, not interested in hearing that. I like what I do, helps me. You know, I really don't want to do that any different. I've got friends that have lived till they're 99. Contemplation, thinking about it. Preparing, thinking about how they might do it, and then moving into action, making the change, maintaining the change, and perhaps moving back into needing to go through the cycle again. And the other thing is that the cycle, you can jump from one to the other. It's not as if you've got to spend a certain amount of time in one part and then move on to the next part of the cycle. You can jump from one to the other, and the way you have your conversation, and this is where motivational interviewing is so fantastic, is the way that you have that conversation can actually help people to move further along the stage of change towards taking action.
Yeah.
So Amanda, where would you put Mrs. G in terms of her stages of change?
In her smoking, she's saying, I think I need to stop smoking. So she's probably at the preparation stage, thinking about how she's going to do that. And then with the drinking, she's saying that she's concerned, but gee, she likes it as well. It helps her. So probably at the contemplation stage there.
And that contemplation stage is a stage at which the using motivational interviewing is really, really handy.
Yeah, that's that ambivalence we're talking about, and that's really what we have to work with, and that'll help people move forward.
Yep.
Have we had any chat from anybody or any questions? And just wondering if Adrian Dunlop wants to say anything at this stage. Okay, let's move on.
So moving on to Mr. H, who's age 45. And Adrian.
Sorry, Hester.
Okay.
Craig. It's Craig and Adrian. We're actually sitting together currently, and we're not quite sure whether you can hear us, but obviously you can now.
We can.
Okay.
Did you want to say anything about the previous screen?
No, we were just going to interject but, to make sure you could hear us. But no, the discussion about the stages of change was good.
Fantastic. So we'll move on to the next slide. So we're moving on to Mr. H now, who's a new patient, middle-aged guy, 45, attends your practice for removal of sutures after a laceration sustained at work. So once again, thinking about how you normalise, ask permission. As part of my routine review of all my patients, this is while you're taking up the sutures, I always ask about lifestyle factors, including things like exercise, diet, stress, alcohol and other drugs. Is it okay if I ask you about these? And he says, yeah, sure. Look, I did have a time when I was really low after my marriage broke up. Really important information about this guy you've got there. I'm doing better now. I smoke cigarettes and have a couple of cones at nights to help me to relax. I drink a bit with the boys. Look, I've used ice a few times in the past. So he's given you a whole heap of information around his drug and alcohol use. So then, with the assessment, in terms of the assess here, this is really based on the audit C. So how often do you have a drink, how much on a day when you're drinking, and how often do you have 6 or more drinks, and that's standard drinks. The other thing you can really use this same audit C for different drugs as well. How often do you have cannabis? How much do you have when you're smoking cannabis? You know, and so really looking at the same with his ice, you could do exactly the same thing. But coming back to his history, he's having 15 to 16 standard drinks of alcohol three times a week. So he's scoring on the audit C. He smokes 5 cigarettes a day. He mixes those with cannabis, and he smokes a couple of cones at night to help him sleep. He's drinking 10 to 12 schooners of full strength beer on the Friday, Saturday, and sometimes Sunday nights. And he's used ice in the past. And importantly, his workplace injury happened on Monday after a big weekend. So just thinking, Craig and Adrian, any thoughts on what might be going on there, and what are the important factors that we've gotten from Mr. G's history?
It's Craig. So my first thought was that he was fairly upfront with disclosing the information. So sometimes that's not always as straightforward, and some people are not as, or sometimes wanting to hide the actual use. But I guess general practitioners are in a good situation that they often know someone much more longitudinally than we do in a hospital setting, and so that does aid the engagement and you know, the confidence that the patient has in the doctor-patient relationship, and getting this information is important. I guess in terms of what he's told us about the drug history, it appears that he's concerned more so with the alcohol use, and so I guess that's probably the place to start with, you know, talking about what he wants to do and what the next steps might be.
Thanks, Craig. And from my perspective, you know, gut reaction is it looks like this guy's disclosing quite a lot. So we're clearly engaging with him well, and try not to slip up by reacting really negatively to his responses. I mean, if somebody comes sort of straight out and says they smoke tobacco, cannabis, drink quite a bit on Friday, Saturday, sometimes Sunday nights, have used methamphetamine. I presume that's methamphetamine, not sort of icy water to put in his beer to make it colder. We're getting quite a lot of information.
Yeah. Move on to the next slide. So Mr. H says, I'm not worried about the ice. I didn't like it. I'm not going to do that again. Cannabis, I really like it. It helps me sleep. Alcohol, yep, I've been thinking about it. My new girlfriend is getting pretty annoyed, and I reckon I was still half pissed at work that morning I had the accident, and that's not okay. I can't do that again. And I get into fights. So, oh, we've moved on. Yes, okay. So, once again, looking at advising and agreeing, you know, so we're expressing concern. And one of the things I think for this patient is that he's kind of going, look, the ice, I tried it, it's not a problem, I'm not going to use it, you know, it's not my thing. The cannabis, oh, really like that. The alcohol, like it, but actually it's causing me problems, and that's not okay. So if we're thinking about where the places to go, and in fact where the most risk is, it's having those 15, 16 standard drinks 3 times a week that are going to cause him the most harm. And so once again, I'm concerned about your drinking. My medical advice is to actually cut down or stop for a while. You know, and thinking about, well, what, you know, how do you want to approach that? Just thinking, Craig and Adrian, in terms of talking to people who are drinking at hazardous or harmful levels, how do we make sure that they're not dependent? How do we know that this guy's not going to withdraw? How do we do that assessment? And what would you offer for him if it was clear that he wasn't dependent and wasn't at risk of withdrawal?
So the quickest thing would be to ask him about the days that he's not drinking, and ask him, is he really not drinking at all those other days, or is he drinking some? And what's he like the morning after those binges? I mean, he might describe hangover symptoms, but does he describe anything that sounds like alcohol withdrawal?
Yeah.
The other thing to add was perhaps ask him if he's had a time where he's stopped drinking for some other reason, like he might have been in hospital, or he just stopped for a week or so himself, or for some reason, and to ask him how what happened at that time, and whether he needed treatment or not.
Yeah. And I think also the thing is, if we're talking to someone about, look, maybe you need to stop, for somebody to come to a decision where they're going to stop drinking is a big decision, you know, and people will kind of think, I've got to stop forever. You mean I've got to stop forever? I don't think I can do that. But for some people, they do come to the point where they go, you know what, just can't do this, need a break. You know, so I would always be talking to people about having a break for a period of time. And how would you realistically do that if you want to stop for a period of time, just to give your body a bit of a rest, you know, and see how things go, to really work with them around what they can actually realistically achieve.
And what would you be saying about his sleep at this time?
Well, certainly we know that alcohol actually interferes with sleep, and so it could be actually making it worse. But the other thing is that he's using cannabis for his sleep, so there's a whole other story there. Should we move on to the next? Oh, yeah. So once again, in the stages of change, I would put, you know, so he's not worried about the ice. Look, really, it's not an issue. And maybe it is, but he's just going, nah, don't want you to go there now. Cannabis, not really sure, really like it. It helps me sleep. So he's maybe pre-contemplative. He's maybe contemplative. You know, so that might be a time to do a little bit of motivational interviewing, or just finding out a little bit more about that. But certainly with the alcohol, he's contemplating change. And from my point of view, this is where the money is with this particular presentation. Let's actually work on the thing that he's concerned about, that is causing him problems. And maybe the cannabis and the smoking will change as a result of that to some extent. But as Amanda said before, you can work on more than one at a time. There's no reason why you can't work on a number of substances if the person's ready to do that. But it's really going with where that person's at. Amanda, did you want to say anything else?
Yeah, I just think, like you said, that exactly go where the money is and make the link between alcohol and sleep. Like you said, that alcohol can worsen sleep. He seems concerned about his sleep. I'd be saying, let's check in about your sleep next time and see if it's improved, and then maybe have a chat about your cannabis then. So it's sort of like foreshadowing. Yep. You might be able to go next.
Yep. Yep.
Yep.
Beautiful.
Hester, it's Craig again. Just on that whole sleep issue, I find it's helpful to explain to them when they first stop drink, that's their decision, and you're helping them work towards that the initiating sleep can be more problematic, but that gradually the quality of sleep improves, even though the falling off to sleep is slightly more difficult. And usually over a few weeks, if alcohol is the only drug involved, usually over a few weeks that does actually improve for a lot of people. Yeah. The potential risk for this gentleman is him inadvertently using his cannabis use to compensate for that process. Yeah, exactly. So coming back to Mrs. G, we're looking at change talk. So my daughter really wants me to stop smoking, and I don't want to disappoint her. My husband doesn't agree with my drinking. I mean, he can drink a couple of beers, but not very often. Once I start, I don't seem to be able to easily stop. I tell myself to take a night off, but I always end up having a drink. I mean, I limit it to 3-4 times a week. I know it stops me losing weight, and I'd really very much like to lose a few kilos. So when you're looking through that, there's a number of points at which you can continue the conversation around, well, how would you like this to be different, and what might it look like? With Mr. H, once again, at the same sentence here, you know, his girlfriend's getting annoyed, and he's actually, there's quite a bit of shame in this sense of, geez, you know, I think I was still half pissed at work that morning, so I was still intoxicated the morning I had the accident at work. That's not who I am. That's not okay. I can't let that happen again. This could affect my employment. And I get into fights. I need to do this differently. So there's a lot of things there that are not working for him in terms of the alcohol. So there's a lot of room to work with him around how he might do that differently. And I do think with Mrs. G, working on the weight stuff is a really, really good hook in as well. So Mrs. G says, yeah, I'd like to cut down on my alcohol and stop smoking. I think I need a complete break for alcohol for a few months, and that will help me lose weight.
Whereas Mr. G says, it's time to cut my drinking. I probably need to stop going out with my heavy drinking mates. They're getting into the crystal and that's not my thing. But my cannabis and tobacco, nah, I don't think I'm going to be able to change that. So there is, as Craig says, a risk that he will increase the amount of cannabis that he's using to help manage his sleep and his feeling of well-being. But both of these people are at a stage where they're saying, I want to move on this. I want to change my alcohol. Okay, so once again, we want to get SMART goals. We want to have goals that are realistic, that are achievable, that are timely, and are actually, you know, it's not just, well, I'm going to stop drinking or I'm going to cut my drinking, or what is it, what it's going to look like, when are you going to do that, how are you going to do that, you know, what would work for you right now. And here are some options, as we said before, these have worked for people in the past, what might help you. And then once they're going, well, yes, I do want this to be different and I actually want to stop, as Mrs. H did, I want to stop for a period of time. Okay, so how long are you going to do that for? How are you going to make that happen? What is it that alcohol does for you? How does it make you feel and how are you going to manage that? And then eliciting that commitment. So at the end of this, what are you planning to do? Let's make an agreement around how you're going to work that and then let's follow up. Sorry, it's noisy here. So yeah, so your SMART goals are specific, they're measurable, they're achievable, they're relevant and they're timely. Amanda.
So thank you so much, Hester and Stephen, Craig and Adrian. That was fantastic having you online tonight, and apologies so much everyone for the technical problem. Just blame the two on the other side of the computer. So they were working hard and thank goodness you got it going for us. Thanks so much for your help there. So we're going to have a third webinar on the 10th of April, starring Adrian Dunlop, Tony Gill and a few other very well-known people. So please join us then or watch it later. It's going to be fantastic. We're going to be looking at best practice for tobacco, alcohol and cannabis treatment. We're going to be talking about withdrawal and pharmacotherapy, ambulatory detox specialist line as well, and lots of other good stuff. Is there anything else that Craig or Steve or Adrian would like to say before we sign off tonight? They're going to reveal all on the 10th of April, so stay tuned.
We just had to unmute several buttons because we're not sure how everything works.
They'll be practicing in between time. Yeah, that's great. Thanks so much for your contributions. And thanks.
Okay, cheers, thanks.
Okay, bye.
Thanks, everyone.
See you guys.
Thanks.
Bye.